Okay, my name is Richard Harding, and I am a general surgeon in Phoenix, Arizona. And I am the moderator of today's NASIT presentation, which is on challenging cases in radiofrequency ablation. Before we start, I'd like to start by complimenting the Jennifer Kuo, as well as her executive committee, for their amazing job at starting NASIT and getting it up and running in a very short time, and essentially establishing a multiple disciplinary group of physicians who are interested in the introduction of thyroidology to the community. And the mission of NASIT is to promote a safe integration of ablative thyroid technologies into clinical practice and collaborative environment that supports education, research, and into the interventional thyroidology. So with this, we'll start by interviewing or introducing our faculty and our panel, starting with Steve Hodak, who is the Chief Endocrinology at NYU Langone in New Manhattan. We have Timothy Huber, who was at OHSU and is now in Hartford, Connecticut. James Lynn, who is assistant professor at OHSU, who's an endocrine surgeon. Julia Noel, also an endocrine surgeon or otolaryngologist at Stanford. And so with this, we'll go to the next slide. We're going to talk about our meeting. We have a meeting scheduled, our first inaugural meeting scheduled in March 2023 at the Omni Royal New Orleans Hotel in New Orleans. And this is in combination with a hands-on course that will be at Tulane University. So we hope you can get online and see the actual program and join us at this meeting. We're very excited for this. Next slide. For all attendees, we'd like you to mute yourself if possible. Turn your videos off. Right now, we should have it already programmed where these are already off. For questions, we'd like to use the Q&A function and type in your questions. We'd like you to please put your email in the questions in case we can't get to them after each session, so that we can answer these questions at a later date. And so we try to answer these questions after the end of each presentation for the point of keeping things together. So, okay, next slide. Our first, these are disclosures. I'm not going to read these. All right, our first presentation is Julia Noel from Stanford University.
All right. Hi, everyone, and thanks for joining us. So this is a case of mine, and she's a 50-year-old woman, bilateral thyroid nodularity. And she presented because she had initially had low TSH that was noted on routine lab work for estrogen management. She was otherwise healthy. She took no medications, including no thyroid suppression. And she presented with the following labs, so suppressed TSH, negative antibodies. And then she had both a thyroid uptake scan and ultrasound done, which we'll see on the next slide. And so you can see on the uptake scan, she has this intensely active right thyroid nodule. And interestingly, on ultrasound, she had almost identical appearing nodules on either side. So these are not mirror images. They are in fact two distinct nodules, the right one being active and the left being primarily cold. And the dimensions you can see above the ultrasound pictures of each. And so we had a discussion about her options, which of course included surgery, especially given her bilateral nodularity. She was absolutely adamant that she did not want to take any thyroid supplementation or suppression, and that was her number one goal, was to remain off of any medication. And so I did perform a single session of RFA for her right thyroid nodule only, the active one. And here are the results at 3 and 12 months. I just saw her about 3 weeks ago, and she's had a nice result. She's had about 86% volume reduction from the initial measurement, and she has had normalization of her TSH, not on medication. And before we sort of launch into discussion and questions, we did want to share a video of hydrodissection, just because this is a technique that I think prompts a lot of questions just for those that are starting to do RFA and then also wanting to sort of advance their technique a little bit. And this is, I think, especially important for treating these toxic nodules, because you really want to be as complete as you possibly can in order to achieve the desired goal of keeping the patient or taking the patient off of thyroid suppression. And so the act of instilling D5W between the nodule and the great vessels, which act as a heat sink, allows you really to go right up to the periphery of the nodule and be able to treat it without worrying about that heat being taken away by the carotid artery. So I know this is kind of a slow video, but it kind of gives you the idea of the D5W kind of diffusing in that plane.
Very nice presentation. So we're all excited about treating toxic nodules, and so we'll just start with basic questions regarding this one. James, do we need to do fine needle aspiration of these toxic thyroid nodules?
Yeah, I mean, I think in the past we had said that for toxic nodules, they're generally associated with benign. They're not mutually exclusive though, and so it's possible to have a toxic nodule that does harbor a cancer. So, the current guidelines are to have at least one benign biopsy. And so I would recommend at least one biopsy of the toxic nodule prior to RFA.
And what about the radioactive iodine uptake scan? Do we need that? Is everyone using that?
Well, I mean, in this case, it's helpful because you have bilateral nodules, and I think you'd have to identify whether one or both nodules were active. So that would be the most expedient way to do that.
Has someone seen a case similar to this where you have multiple nodules on one side and you have uptake in the iodine, but it's not as bright or dramatic, but yet it's still much hotter than the other side?
So you mean you have like a warm nodule on one side and a hot nodule on the other? Yeah, you can.
Exactly.
Yeah, you can have that.
Yeah. So I personally had that and had some significant success with ablating and correcting their thyroid function. So next question. Should we treat the same? Should we do both nodules? Tim, why don't you go far away on that one?
It's a good question. In general, we recommend against treating both nodules at the same time if they're on contralateral sides, just because you have the risk of nerve injury. If you have bilateral nerve injury, that would be pretty unfortunate for the patient, pretty exciting during the procedure. So we generally recommend against treating both sides. I would say, especially for people starting out doing this, do not try to attempt that. But as you get more experience in the practice, I think there are some cases when you could consider that if the nodules are farther away from the nerves, then you could potentially consider that, but I wouldn't start off doing that.
Yeah. Next question. All right. Expectations. So Julia, can you talk about what you did in terms of energy for this patient per ml and what you expected to see with that?
Yeah, and I think this is a component that goes into a lot of the counseling about whether or not to do this in the first place, right? Because we don't know for sure that RFA is going to render a patient euthyroid when they have a toxic nodule. And so I think the location of the nodule and the size of the nodule play into that significantly. The nodule does need to be in a location that you feel like you can do a very thorough job ablating it, because we know these nodules are very vascular. They are hyperactive. They tend to, recur and cause persistent hyperthyroidism. So there's a lot of literature that shows that if a nodule volume is on the lower side, some studies have suggested 12 milliliters, some have suggested 20 milliliters. And I think that is perhaps a little bit less important than, can you see the entire nodule? Can you get to the entire nodule? And and can you do a good job of ablating it? Exactly.
Can I,
And so, yeah, go ahead, Steve.
Can I, I was just wanted to expand. I think you're exactly right. I mean, I think this idea of having a size cutoff is a good guideline, but the simple fact is bigger nodules are harder to treat. Smaller nodules are generally easier to treat, assuming they're not in some crazy difficult location. The important thing that I think about toxic nodules is that these are clonal neoplasms. The cells have a survival advantage or growth advantage over the rest of the thyroid cells. And if you leave parts of toxic nodules behind, they want to regenerate because they want to grow. They have a growth directive that's programmed into them. So it becomes even more critical when you're treating a toxic nodule to get a complete extirpation than when you're dealing with a hyperplastic nodule, which is not neoplastic.
Would you agree that these take more energy just in the prosecution of the case, that you're seeing that the nodules do not change with with the lower energy, and it takes more time to ablate these?
I've actually had both extremes. I've certainly had that circumstance, but I've also had known toxic nodules where I'm turning my wattage down to like 25 or 30 because the ablation is going so quickly, and I want to be able to see where I have and haven't ablated. So it's interesting. I have had both ends of the spectrum.
I think really the only way you could answer the question is by knowing what the energy per unit volume is that you're delivering at the end of a case, because I'm sure everybody does this a little bit differently, but when I'm doing a case, I'm a little less concerned about what the energy setting is, and I'm more concerned about how quickly am I seeing the hyperechoic change around the needle tip, making sure that it's not too fast, making sure that it's not too slow, and I'll adjust the energy based on what I'm seeing, that direct feedback of what I'm seeing. If I don't know that I have the sense that it takes more energy to ablate a toxic nodule. I tend to try to get a lot of energy into every nodule because I think that correlates with a good outcome.
Right. As long as it's well tolerated. Let's go to the next question. All right. Well, we just talked about those. Yeah, that's good. So, and then here's how do we manage these afterwards? Tim, how do you do it in interventional radiology?
Yeah, so we follow these folks basically with repeat labs, labs at baseline and repeat labs at 1 month. And then we're following them every 3 months until they normalize and stabilize. Oftentimes medications can be stopped around the 1 to 3 month mark. In my experience, I'm not sure what you guys are all doing, but in my experience, usually by 1 to 3 months, most patients are back to euthyroid state if you get a complete ablation, and most can come off medications pretty easily.
Anybody just stopping them right away?
Yeah, I am. I think practically every toxic nodule I've done, I've stopped the patient on the day of treatment. And I think, you can rationalize that. If you're ablating the nodule, you're probably also destroying all the stored thyroid hormone inside the nodule as well, or at least disrupting it. So I haven't had any patients who've been symptomatic. I generally follow up with thyroid tests within a couple of weeks of treatment. Haven't had any patients who've had recurrence. So I feel pretty comfortable in most cases stopping the antithyroid drugs immediately after treatment.
And that's been my experience as well. And maybe I give it to them the next day, and that's about it. So how about retreatment? When would you retreat? James, let's go back to you.
Hopefully never, right?
All right. So.
Ideally, yeah.
Yeah, I mean, that's a good question. I mean, we basically followed them out, at 30 days, 3 months, 6 months right now. And specifically for toxic nodules, just like everyone else has said, usually by 30 days, we're seeing, that they're euthyroid after the ablation. We haven't had one yet that has required retreatment. I think there are a couple where on ultrasound, you can see that there's some marginal kind of edge that may be viable, but we're just kind of watchfully waiting right now. Probably indications for retreatment would be, obviously if they had recurrence of their hyperthyroidism and there is clear evidence of regrowth, I think those would be reasonable to consider retreatment at that time.
Okay, let's go to the questions real fast before we start the next case. So some of the questions are, does anyone do this under local anesthesia versus conscious sedation in IR/OR? So I'm personally doing under local anesthesia in my office, which is lidocaine. Anybody doing it other than that?
In IR, but otherwise local.
Okay.
Yeah.
So local anesthesia, right?
Unless the patient really has significant comorbidities, especially cardiac, that need to be monitored, or the FNA went really poorly and you know that they're just not going to tolerate it that well.
Right. And that's hard to arrange, but I've had a patient who has seizures after a simple FNA. So that patient is not a candidate for RFA, at least until I can arrange anesthesia for that patient. All right.
Yeah, I think we will give some benzos, just to get some anxiety to improve that. I think if they're very anxious, we have had Tim when he was at OHSU and Dr. Park, who's there now. They'll do it under sedation. I think the main thing is it's really light sedation that you're aiming for. You just want to make them comfortable. You want them to still be able to speak to you. You don't want them to, I think there's a certain element of safety when they're able to kind of still have that sensation and be able to respond.
I think the benzos are a huge help because they cut down on a lot of the hypervigilance and a lot of the anticipatory anxiety that people have, and it makes them far more able to tolerate the procedure with very little difficulty. So, while I'm agreeable to do it without benzos, if the patient insists, a 0.5 milligram of Xanax or 1 milligram of Xanax goes a long way when you're doing these cases.
Right.
Yeah, we did a few with moderate sedation on some very anxious patients early on. And they got a little bit snowed and it was a little too much. So we backed off and started offering like an Ativan or Xanax before the procedure to really anxious patients. And that's a much better, I think, better tolerated way to do it.
Fantastic. There's another question regarding how following these patients with radioactive iodine uptake or just simply biochemical, in terms of following these patients. And there's some studies that show giving radioactive iodine in combination with RFA has been very helpful in managing these patients, but even that seems excessive. Anybody doing anything other than simple monthly or blood tests every 3 months? We're all doing ultrasound on these patients.
I can't see a point of doing a radioactive iodine uptake, a diagnostic scan, if the biochemistry is normal.
Right. So, okay, let's go to the next case. So this is James Lynn's case. This is a really interesting case. We enjoyed talking about this one. So.
Yeah, thanks. This is a patient I saw in consultation actually earlier this year. It was a 50-some-year-old woman with a new presentation of a left neck mass that was causing cosmetic and new pressure symptoms. Her history is interesting. She had undergone a total thyroidectomy in 2009 for multinodular goiter. The final pathology was benign. There were no postoperative complications. She did have some voice changes that, there was no permanent vocal cord changes on exam. But that was one of her hesitations to proceeding with, potentially another surgery. And she was already on full replacement dose of levothyroxine. And on imaging, on ultrasound and CT, basically it demonstrated which looked like a large, left substernal mass, which, if you hadn't told me she had a total thyroidectomy, I would have assumed, it was still left thyroid. She had a fine needle aspiration biopsy that was performed, and it was consistent with benign thyroid tissue. But basically, she presented asking of whether or not we could perform RFA so she wouldn't have to undergo another operation. You can see here some representative cuts on ultrasound, really nothing too concerning on the ecotexture of the ultrasound. And then really what you need to see is the CT scan here. And you can see, if we can play the clip, that you see demonstration of this large left thyroid. I think it paused, but if it continues going all the way down, basically down into the anterior mediastinum and all the way down to
the aorta.
Yeah. So, so it was interesting. I think it was kind of a thought experiment because, I've heard much about folks ablating substernal nodules and doing it in a staged kind of procedure. And, that substernal portion of it will magically get pulled up into the cervical neck region so that you could go back at it again with a repeat ablation if necessary. But if they've had a total thyroidectomy in the past, would that get pulled up or would it get pulled down?
Yeah, so Julia, what do you think about that?
Yeah, I'm on the same page as James. I think there's not a lot of advantage necessarily to doing RFA over surgery. She's already on replacement dose, full replacement dose, it sounds like. And I think the outcome of RFA is uncertain in the context of scar tissue that may kind of limit that effect of, pulling the mediastinal part up into the neck so that it's accessible the next time around. So I would say this is not the best RFA candidate. It's technically feasible. I don't think that means that you should necessarily go for it.
So this is a big thyroid nodule. It measures about 60 mLs in size, and it's pretty deep in the chest. How difficult is that operation to do?
A lot of times it can be relatively straightforward. A lot of these big benign nodules are amenable to being, scooped out of the mediastinum with some gentle blunt dissection, and it can be done safely, certainly.
So I'll just throw this out to the panel about in regards to access to the substernal plane with ultrasound, and then also with a probe. How difficult is it to access this with the needle? Steve or Tim, have you had to do anything?
It's going to well, look, so I mean, it's going to depend. I mean, and I think this is one of those cases where you would have to actually look in real time to see how much of the nodule you can visualize and what kind of angle you would have to throw below the clavicle to get your transducer needle in there. You can't treat what you can't see. And if you were able to easily see 90% of a deep nodule like this, I don't think you would, then maybe it is a candidate for RFA. But I think because of the location of this nodule, you're not going to be able to treat it effectively from the access that you have at the level of the clavicles. So surgery probably is the right thing. Though I wanted to ask, what's the indication for any intervention in this patient at this point? It's a benign nodule. Is it growing?
Yeah, I mean, certainly it's grown since, her last operation, but when she presented, it was cosmetically apparent and she was having pressure sensation.
Gotcha. Yeah, so then you have to do something. I would think surgery is a better answer in this case.
Right, she's already on thyroid medicines and she has a scar, and it's in basically an unoperated field. Essentially, it's below the previous surgical field, so it should be pretty straightforward. So, all right, let's go to the next one. These are Dr. Hodak's cases.
Oh, okay, great. So this is an 83-year-old retired female medical doctor, and she has an enormous goiter. And her TSH varies between sort of low normal to suppressed. The goiter's been repeatedly benign on cytology. You can see in the CAT scan, as we kind of march down into the superior mediastinum, there's just a big heterogeneous bilateral goiter. It's bigger on the right than the left. And if we play that transverse ultrasound, that clip that's next to it, that's only to show that the goiter has sort of a similar appearance. And I think it's probably really a coalescence of very large, very bland appearing nodules. So this is truly a benign structure, but it's big. And over the many years that I've been following her, it continues to grow. Her TSH is a little bit on the low side. Symptomatically, it really doesn't bother her. It's big, it's noticeable. It looks like she's got a big fat neck. She doesn't really care about that too much. What bothers me a little bit is that she's getting older, it's getting larger. Her TSH seems to be trending now to the point where it's getting more frequently below normal. So one of the things I wanted to at least consider was the possibility of radiofrequency ablation for treating this goiter, but there is no discrete target. The goiter is really diffuse. So really the questions are, can you use radiofrequency ablation in a structure like this to effectively cytoreduce a big thyroid mass, understanding that you're not targeting a specific nodule and you're not trying to make a specifically defined mass within the thyroid disappear? I would think the person I'd want to hear from on this is Tim, because in the IR world, there is some experience with doing embolization of thyroids. And I think this procedure is most akin to that type of approach.
Yeah, so there is literature out there about using RFA to cytoreduce big goiters. There are reports out there, not large series, but it has been done before effectively, just to reduce tissue. So it can be effective. In this situation, we're trying to reduce, to normalize thyroid function potentially, a little less well described, but conceptually it seems like it would make sense. There is the technique, like Steve was saying, this thyroid artery embolization, which folks are doing a bit more in the IR world. Not widespread by any means, but essentially going in radial access, going up into the thyroid arteries and using small particles to embolize thyroid tissue. Typically more for very large goiters or Graves' disease, things like that, where it's a large or hypervascular and it's sort of a sump and will suck up the beads preferentially. Not a large stroke reported rate with the procedure, although it's a little bit nerve-wracking to be doing this procedure in that territory with particle embolization. Very much a specialized type of procedure. But some small series published recently have been showing that it can be effective with a relatively low complication rate, but still very early days for that, I think. Hopefully we'll see some more data on that, and hopefully it'll be a potential treatment option. But it gets very hard to push for that when you have such good options like RFA, like surgery, that really don't carry any sort of stroke risk. So I think that would be only something reserved for a very limited subset of patients who wouldn't be candidates for either surgery or RFA, which I can't imagine there'd be a whole lot of those.
So as we are stewards for this new technology, we have to think about obviously safe introduction and when and where it should be offered. But is there a setting, a research setting where these things should be, at least a trial setting where we should be looking these and enrolling people in trials for more, beneficial, information collection for everyone's standpoint? In other words, not just do this and see what happens, but actually collect data for the purpose of a trial.
That's a great question. I think we're hoping that as part of NASIT, we can put together a registry and start collecting more data on the patients that we're treating. I think for something that's sort of as new and untested as embolization, definitely needs to be performed on trial at a bigger center that specializes in this, probably with neurointerventional backup. But in terms of more broadly, just research collaboration, I think we're all hoping that we can work on creating more of a network to support that effort.
Tim, the question that I was thinking about in regards to this case, which is the connection to the embolization literature, is I think it's feasible to basically necrose a very large block of thyroid tissue and not have a problem with, an inflammatory change or an abscess or something like that. So I think it's a reasonable strategy. The last question is, if I successfully treat this goiter, reduce its size, if TSH rises, would that become a trophic signal to the goiter and cause it to regenerate itself? I'm not sure that anybody would know the answer to that. I suspect it would happen very slowly if it was going to happen, since I doubt this is a clonal process. But this patient's 83, and I think if we can treat this thing and manage it, shrink it, restore her thyroid function, she can live hopefully the next 10 or even 20 years of her life and not have to worry about this thyroid. And that would really be the goal of the treatment.
Yeah,
So
and the question
Steven,
is, go ahead, Julia.
I was going to ask Steve, so if you did decide to offer this to her, would your strategy be to ablate as much as you can in one session, or would you kind of try and break this up in pieces and do it a few months apart?
Well, yeah, that's a great question. I mean, the right lobe is considerably larger than the left, and I think I would probably just focus on the right lobe. And I think what I would probably try to do is, start as inferior as I could with good visualization, and then just work superiorly and see how much I could treat. I do think that if we're able to treat this goiter and shrink it, it's going to sort of collapse in on itself, and it'll just remove some of that mass effect. The goal would not be to, completely obliterate the goiter, but just to cytoreduce it, like I said. So I don't think I would work bilaterally necessarily, but, you could make that decision in real time as you're treating, depending on how things are going. I would probably use a 1.5 centimeter active tip, and I'd probably be working with pretty high energy, especially in the central portions of this nodule, to try to get as much heat in there to diffuse it and kill as much tissue as possible.
And
So
Steve, that
interesting-
superior extent, does that worry you at all, how high it gets in the neck?
Pardon me?
That the superior extent of that, being such a large goiter, treating so high up in the neck, do you worry about that?
Well, I mean, I don't really get worried about location in the neck as long as I can see it and I'm in control of the adjacent structures. I mean, I think that if you're working around at-risk structures in particularly precarious places, especially if you're using a big active tip, that's where you got to start thinking about dialing down your energy, being very precise about where you're delivering energy. I think we all agree that this radiofrequency ablation procedure is simple, but it's not easy. The concept is very basic. The hard part is making sure that you are precise and very on target about where you're delivering energy, and that you're thinking about things like thermal spillover. When you're creating a thermal well inside the thyroid gland, where's that heat going to go? If you're very close to an adjacent structure, you potentially can injure it indirectly by that thermal spillover effect. And so those are the things I think we need to think about.
So when you look at this CT scan on the left side, even though the left side is smaller, the left side has this retroesophageal component that certainly could contribute to dysphagia on this patient. So if she had dysphagia, the question would be, which side would you start with then? Because right there is where you see all the retroesophageal component, and you can't really get there with RFA. That just, I can't imagine that'd be anywhere close to being safe. But the question is, would shrink that left side pull that away from the esophagus?
Yeah, I think that's exactly right, Richard. And if she had dysphagia, starting on the left side, even though it's smaller, would probably make sense. And then the hope is, as the accessible portions of the goiter sort of involute, it'll pull that retroesophageal portion or retropharyngeal portion out.
Yeah. Can we go back to the, I don't think we have any questions to ask on this following this, but I was going to go back to James's case. There's a question regarding that the substernal thyroid, whether or not there'd be any benefit to attempting the RFA to shrink it first to see if it resolves her symptoms. Can we address that quickly? This is James's case.
I mean, I think that sort of gets at the question, do I make surgery much more difficult by performing RFA first, right? Because you could approach this by saying, okay, well, we could try it and see if the symptoms resolve. And if we try it and it doesn't work, have we burned any bridges? And, I personally don't have enough experience of previously ablated nodules to say whether or not that makes this particular type of surgery more challenging. I think in the thyroid that is not substernal, the dissection is very much the same, especially in theory, as you haven't penetrated the posterior capsule. And so where it counts, the surgery is essentially identical to a virgin neck. But, with scar tissue previously from surgery, and then perhaps the additional from radiofrequency ablation, what would you then make it more difficult to deliver this from the mediastinum? And I think that's just something to think about.
I think my 2 cents on that.
Right.
Oh, sorry. I was just gonna say my 2 cents on that. I think this is part of the, being good stewards of new technology and what are our expectations. And I think, with RFA in general and patients, I think expectations are huge. And so as part of, the evaluation, the ultrasound, I think, is very key in trying to replicate or exacerbate maybe the symptoms that they're having, to making sure that what you ablate and what is shrinking is actually the cause of their symptoms and their concerns. Here, I just would have zero confidence, in terms of how low we'd be able to get to actually, reduce, what's actually pushing the trachea over. I think it's not uncommon to ask, well, should we try it or should we just go to surgery? I think for this one, though, it seems more clear cut that surgery would be the ideal.
I agree. I'm in more favor of just getting it out all together in one piece, not necessarily one, just all together, so you don't have to worry about monitoring it in the future. Because it would be very difficult to monitor this with just simple ultrasound in the office. So I think you'd be basically subjecting her to repeat CAT scans on a regular basis.
And that's one place where the pre-procedure evaluation is helpful. If you ultrasound them in clinic beforehand, sometimes with patients with neck extension, you can manipulate kind of the neck in a position where you can see the full extent, more so than like on a CT scan, and kind of reassure yourself that you'll be able to follow this and visualize the whole thing, but not all the time.
All right, let's go to Steve's next case. This is a very interesting case.
Yeah, so this is a 66-year-old Asian woman who has an unstable airway and a thyroid cancer. And her story is that she had a history of a benign partial thyroidectomy in China in the 1990s. Subsequently, she developed pulmonary fibrosis, had a bilateral lung transplant in 2011. And following her thyroid surgery, and perhaps because she had primary hypothyroidism, she had been on stable chronic thyroid replacement. In the course of her follow-up, she was found to have a 12-millimeter suspicious nodule in the left lobe, which was biopsy-positive papillary thyroid cancer in 2013. The complicating factor in this case is that her airway is severely compromised. She has complete paralysis of the right recurrent laryngeal nerve with adduction of the right vocal fold. So the cancer's on the left, the right vocal fold is completely paralyzed and medialized. And she also has a partial paralysis of the left recurrent nerve with nearly complete adduction of the left vocal fold. She effectively has a 3-millimeter airway. She's considered a poor candidate for gold standard surgical management because there's a very high risk for tracheostomy if that remaining left recurrent nerve function is impaired. But the papillary cancer is chronically stable on observation. So the way she was initially managed was just with continued observation, and the cancer basically behaved itself. The real difficulty started when she subsequently developed renal failure, and she wanted a kidney transplant, but the transplant team said she could not be listed with an active malignancy, the papillary cancer. So here's a transverse view of the left lobe, and I think you can see sort of just next to the tracheal wall, there's this very hypoechoic, irregularly bordered lesion with spiculated margins. There's some calcifications inside. That was the papillary cancer. And this was prior to what we ultimately did was radiofrequency ablation. It measured 14 by 8 by 15 millimeters. 6 months post-operatively, it doesn't look all that different. But the way we tried to investigate this was with multiple fine needle aspirations in the area around the nodule and within the nodule. And those aspirations confirmed that there were no viable cells. There were just stromal elements and debris. So we had effectively been able to extirpate this cancer. And ultimately, she was listed for a renal transplant.
So that's a fascinating case. So the first question we had about immunocompromised patients, should we even be concerned about treating these patients who are immunosuppressed? I mean, does anyone have any concerns about that? Apparently not. So let's go to the next question. So good. I didn't have any questions. So here you are, a woman who's got a contralateral injury and a partial nerve incompetence on that same side, and so here she's a major airway risk. And so, what makes this safer than surgery? What makes it safer than surgery? So, that's a question I had in terms of, and where would you do this procedure? So, James, I'll just start with you, and we'll just kind of go up the list.
Yeah, I mean, I think, this is a very challenging case. I think RFA, in my mind, is less risky than a general anesthesia. You could have injury to the vocal cords, swelling postoperatively, and if she already has a very small airway, even if you didn't injure the vocal cord nerve, it could lead to, some airway issues. And then, with the surgery itself, I guess, she had the lung transplant. I guess I don't know how much scar tissue is in the area of the region of the thyroid, but obviously some element of that is going to be not virgin. And so with that scar tissue, yeah, I think it would be someone I think long and hard about before offering surgery to.
So Julie, what is the risk of airway injury just with intubation of this patient?
That's a good question. I mean, even as James was saying, without any nerve injury or manipulation, just the act of intubating and keeping an endotracheal tube in there for a couple hours, while you're doing the case is going to cause some edema, that will potentially compromise the airway, and the patient will be at least stridulous, if not symptomatic from her airway compromise. So this would definitely be a patient where you're probably watching overnight in the ICU and maybe giving steroids, even if everything goes smoothly surgically.
Just, historically, this patient absolutely refused surgery, and our surgeons didn't want to touch her because they thought the risk of tracheostomy was so high, and she was not interested in a tracheostomy. So she said that that's something she would not be willing to live with. So this issue of could we do RFA safely became the discussion. And I think in this case, it was the location of the cancer that made me feel fairly comfortable that we were not going to be at high risk for jeopardizing that little bit of nerve function that she had left on that side. I think if this malignancy had been deeper and more, located more inferiorly and more medially where, the recurrent nerve is more likely to be involved, it would have been a different story. Not that it couldn't be done, but there might have been a higher risk of injuring that nerve and basically losing the airway during the procedure. And that would be next to a disaster if that happened.
Can you, Scott, comment on your treatment of that medial margin next to the trachea?
Yeah, so the question was whether I'd be able to get a good ablation without making her uncomfortable, because there's lots of nerves in the trachea and it's a very uncomfortable place oftentimes to work. I was ready to do a hydrodissection if I needed to. She was remarkably stoic, and I felt like I was getting a very good treatment margin around the tumor. So I did not hydrodissect it off the trachea, but that would have been an option. That would have been an option.
So on a technical standpoint, we can go to the next question. The technical aspects I had questions about, because I haven't done cancers myself, is whether or not there's a difference in how the nodule changes during the treatment when you activate your radiofrequency probe. Do you actually see the same types of changes in the tissue to know when you're done ablating these areas?
So yes, you do, but some of it's going to depend on the character of the nodule. I mean, if you have a nodule that's really fibrotic and really calcified, you might not see the same sorts of changes. In this case, you're right, it was a little bit more of a struggle. This was a very sticky, sandy nodule. When I describe how it felt when I treated this one, it felt like sticking the needle in a hacky sack. It was a bag of sand, and the needle would get stuck in the nodule. As I was trying to pull the needle back, the whole nodule would move. All of a sudden, the needle would let go. It was a, technically difficult case because the nodule was so sticky, but we got the job done. And fortunately, she did really well.
I found that anecdotally, these seem to ablate a bit faster than other benign nodules. I don't know what you guys think or what you guys have in your experience, but for me, they seem to cook a little faster.
Okay.
And on a technical note, I found when you have it sticking, just kind of twirling the needle as you're kind of pulling it back will kind of separate.
I was like a drum majorette twirling that needle. It was just, it was so sticky.
So is FNA, what do you think about doing FNAs after the fact?
You mean, were they hard? No, you mean, yeah, that wasn't hard at all.
But is it valuable? I mean, do we trust it? I guess as the
Look, my outlook here is that this woman was already immunosuppressed. She had a small papillary cancer that wasn't growing.
Right.
The renal failure was the bigger issue in her life, and trying to treat this papillary cancer was sort of just the way to get her to kidney transplant. Even if I hadn't completely ablated this tumor, I think in the long run, her getting a kidney transplant was not going to change her outcome based on the presence of this cancer. So it was sort of an opportunity to see if we could do it and also help her get a very important medical intervention. But I wasn't really terribly concerned about what if I don't get it all, or what if the treatment isn't completely effective. I think, you know, in lieu of any other way of evaluating this, doing fine needle aspirations and looking at what the cells look like is a pretty reasonable way of assessing whether you're getting a good treatment response.
Did you
Did you
need
do
to
all-
get the FNAs for the transplant? Was that part of their requirement, or was that just for your benefit?
Well, I mean, I think it was just to prove that I had done what I said I did, but it was driven by my interest in being thorough. The transplant people, they just said, oh yeah, just tell us when you do the RFA and we'll list her.
Okay.
Did you do any
Well,
posterior hydrodissection in this case? It looks like you had a pretty good margin to nerve
I did.
territory, but just curious.
Yeah, I did not do any hydrodissection in this case, but I was prepared to do it if I needed it. I just didn't feel like it was going to be further helpful. But this is a case where potentially you could run into trouble with pain due to, you know, heat or heat injury at the trachea, and you'd want to really take this tumor off the trachea, and hydrodissection would be a great adjunct here.
Okay, let's move along. Okay, this is actually my case, and this is more of a tumor board question, and in determining whether or not this patient is an appropriate patient for RFA. And this is a 33-year-old white female who has a symptomatic left upper thyroid nodule that she can see. She presented last year with normal thyroid functions, and she doesn't have autoimmune thyroiditis. And she was treated elsewhere, or at least biopsied elsewhere, and the biopsies came back follicular lesion undetermined significance with a suspicious genetic sequence and classification, but the malignancy indicators were negative. And so the patient doesn't want surgery. And so in order to help clarify the issue, I performed a core needle biopsy, and this core needle biopsy came back as benign. And so the patient truly didn't want to do anything. And so she just kind of waited and not doing. She says she's a nurse. And then she came back, about 9 months later, and the nodule has grown actually from 3.5, 5 or up to 3.5 in largest dimension. And overall, her volume has gone from about 4 to now almost 6 mLs in size. And so I thought I'd do a tiebreaker. I thought I'd send it for ThyroSeq and see if we can do genetic testing on this follicular lesion. And again, the cytology now returned as benign. And so my question for the tumor board, not difficult case board, but the tumor board was, how adequate is my cytology and my FNA workup, or my TrueCut biopsy workup, for determining that this is a benign nodule? These are the pictures of the nodule. It is quite solid, and I would say that it is not definitively benign on ultrasound, but it's clearly getting larger. And I have had some nodules that look like this that have come back as minimally invasive follicular carcinomas. So that was the question: is what is the best way to work this woman up who does not want surgery? And this was initially set up for Steve here to comment on. So,
let me disclose again that I've taken
slide.
speaking fees from Sonic USA for speaking about ThyroSeq. It's a test I use. It's a test I like. I think, though, that this case makes the important difference between ThyroSeq and Afirma pretty clear. Afirma returns a result that says suspicious, and unless you have a tumor that has a BRAF mutation or a RET fusion, it's not going to tell you, unless you do a lot of additional testing, what the discrete genomic landscape is of this tumor. You could do the gene atlas test that they offer at an additional cost. I have some concerns about that as well. But in my mind, checking a molecular diagnostic analysis of this nodule with ThyroSeq would make a lot of sense. If it looks like a histologically follicular lesion, this is not going to be a conventional variant papillary cancer. It's not going to be BRAF driven or BRAF like. This is going to be some sort of RAS-like neoplasm. And if what you found on ThyroSeq was that there was an identifiable clonal mutation, I think that would start to make radiofrequency ablation less appealing, though not impossible to do, and surgery a better option. And I think ThyroSeq will offer that kind of information just with the first test result. Afirma can't. And so I do think that's a good idea, even though you have a benign cytology. And Sonic will usually work with you to get that paid for in these cases where it would be further informative.
Anybody else want to comment before we go to the last case?
So just sort of a
Yeah.
step back, the ETA guidelines from Europe and the Korean guidelines, both basically say benign nodules only. The intermediate cytology nodules, they're not really recommending RFA4 yet. I think there's still a lot of work to be done research-wise to sort of show the safety of doing this procedure in the sort of intermediate grade cytologies. So again, probably a thing to be wary of, especially if you're just starting out. But maybe if you're at a higher volume center, it's something to consider or do on trial.
I also recommend, I'm not sure if you did this, Richard, but if that original pathology that was a FLUS was done at an outside institution, you could have it reread, if you feel like at a higher volume center to see if they would reread it as
Well,
benign.
it was read at the Afirma, so they do their own cytology there, and I would imagine they're pretty high volume. So, questions from OHSU: does anyone stage large thyroid nodules? Not sure what they mean by that.
I think they probably mean doing large nodules in multiple procedures where you're trying to, what we were talking about before, treating the more superior aspect, letting that volute and the inferior aspect rise up. I mean, the issue is when you're doing you're treating in multiple stages, there's an incremental expense for each of those procedures. And you just get to a point where it's no longer it gets to be cost prohibitive unless you can figure out how to get free electrodes. And I don't think anybody could figure out how to do that.
Yeah.
I think, go ahead, Julia, sorry.
I was just going to say, I do try to do as much in one session as I possibly can, specifically for that reason. There are some patients, we alluded to the patient with the substernal nodule, where I know I can't see the bottom, 10 or 15%. And that's someone who we've discussed ahead of time that we might be doing this in 2 sessions. But barring that, as long as the patient's comfortable, then I think it's advantageous for, financial reasons, insurance reasons, to do as much as you can in one session.
Yeah.
And that kind of ties in, I think, this question a little bit with one before, also from OHSU, asking about ablating large nodules. How many punctures do you do, and faster procedure time? Like Steve was saying, longer active tip can definitely speed up your procedure time, which is helpful. Got to be careful with the amount of wattage you're putting in, but that can move things along a bit faster. And I find for most of these larger nodules, I can get away with usually 2 punctures, maybe rarely a third, but in most cases, 2 can cover the majority. Staying in one spot for too long, kind of wasting time, probably isn't very effective, and moving along to another puncture might be effective to speed things up.
I think the other thing, sorry, I was just going to say, last thing is patient comfort, I think, is pretty important. And I found that, especially as a lot of our nodules, I think that we're all treating are on the larger end of the spectrum. Little things like not as much neck extension, throughout the procedure, telling the patient to relax their shoulders, oftentimes they'll be tensing up throughout the whole procedure. And so you need to kind of just remind them to relax. And that will keep them more comfortable and able to tolerate, I think, a longer portion of the procedure.
So another question in regards to the cytology, basically for Bethesda 3 or 4 lesions, they were asking if any of the panelists are offering RFA and for patients that have benign molecular testing. And personally, I do it when the patients are really refusing surgical removal, and in which case, they basically are just absolutely not going to do it. So that's the only time that I've been doing it in that situation. Anyone else?
Yeah, we've offered it before, with that caveat, very long discussion with patient that, there's a risk to doing it this way and not taking tissue out. And some are not okay with that and they want to have surgery after that discussion, and some are okay with, you know, that risk.
So in Brazil, they don't have these molecular tests. They just have biopsies. And so that's one of the reasons why they do a lot of core needle biopsies to get as much tissue as they can. And they're big advocates of core biopsies as opposed to FNA.
I kind of have a problem with that, because I think that, you know, again, when we're talking about these histologically follicular neoplasms, what defines them as a cancer is invasion. And unless you're catching that focus of invasion in a core, which is like frequently a needle in a haystack, what you're going to see is a lot of very bland looking follicular cells. I don't know that a core is a better way of resolving these nodules than a fine needle aspiration, though occasionally it can be helpful. So I think you really have to be careful giving core biopsies more diagnostic heft than they actually have. And
so to respond to that, I have had an 8-centimeter tumor where the gentleman was seeking an RFA specifically, and for other reasons we ended up doing surgery. And in fact, his 8-centimeter lesion was a minimally invasive follicular carcinoma. And so even though the biopsy of the core was benign, so his first cytology was FLUS with a suspicious afferma. And then we did a core, and he had cancer elsewhere that we had discovered on his workup. And so we operated on him. And in fact, that came back as a cancer.
Yeah, I mean, I think people should really think about how molecular genetic testing may make sense to use for evaluating these nodules, because the residual cancer rate in a molecular negative nodule, whether we're talking about an Afirma test or a ThyroSeq test, is extremely low. And if you look at literature about the false negative rate of cytology, often that molecular false negative rate is lower than the false negative rate of actual microscopic diagnosis with negative cytology. So in many ways, it can be the equivalent of a negative cytologic diagnosis, but you have to factor in all these other clinical issues about size of the nodule. Can you treat it completely? What does it look like? What's your pre-test suspicion about whether a nodule is a neoplasm or perhaps even a cancer? And you don't want to treat big, ugly nodules and ignore their appearance.
Right. Thank you for that. So
I think the reliability, I was just going to add, the reliability of the patient goes into that a lot also. I've had a number of patients who are really interested in having their indeterminate lesions ablated. And, you know, I'm only willing to entertain the possibility, assuming genetic testing has indicated a benign nodule, if they're local and they're going to follow up. You know, I think a lot of patients might come for RFA from far away, from out of state. And, you know, I don't know that those are the ones to be doing this for, because I'm not sure that they're going to come back to me to ensure that this is behaving appropriately and not, there's not concern for something else.
I think that's very important, because we all have patients who truly insist they're going to come back for follow-up, and you never see them again. Even after a really wonderful, successful ablation, they just don't come back. So I think that's a really great point, Julia. I think what we should just finish this up. There are some questions regarding insurance coverage. There's some questions regarding training experience. And to be honest, we're going to be talking about this in our meeting in March, which will be, again, our first national meeting. And it's an all-day Saturday and half-day Sunday meeting. It'll be our first meeting for the North American Society of Interventional Thyroidology, and we invite all to come and attend. I'd like to thank our panelists.
That was a good segue, Richard.
So I'd like to thank, because there's a lot more to talk about. We've got a lot more interesting cases that we're going to do for more webinars, and we're all very excited to talk and to present our cases, and so there's going to be a lot more of these moving forward. So I'd like to thank everybody for attending, and thank our panelists for an excellent presentation.
Thanks, guys.
Thanks, guys.
Thank you.
All right.